Welcome to the PHU Clinical Academic Hub podcast. My name is Chantal Osler and I'm a consultant clinical academic, which is essentially a clinician who's also leading research relevant to their speciality. So I'm a physio and I specialise in prosthetic rehab. And with me, as usual, on the podcast journey is Rosalind Austin, a cardiology clinical academic nurse. And so this is the first for the Reviewing the Evidence series, which we normally align to the monthly educational hot topics. But today we're doing a slightly different approach in that we are featuring a version of a journal club working with a particular clinical team. And so today our topic is rehabilitation following stroke. And we have a series of amazing specialists with us today, and I'm going to get them to all introduce themselves so you know who we're working with. And then I'm also then going to move to Claire, who's going to tell us a little bit about the team and where they work and the patients that they see. So if we go round the room, if I finish with Claire, because Claire's going to tell us a bit about the team. So if I start with Shay.
Hi everyone, and thanks for having us. My name is Heidi Janssen and I am a trainee consultant physiotherapy on a programme funded by Health Education England on the stroke and neurology pathway, but I'm employed by Portsmouth hospitals, and so that's why I'm here today.
Fantastic, thanks Shay. Jim?
Hi, I'm James Oldham. I am an occupational therapy team lead working in stroke and neuro rehabilitation here at QA Hospital and Lotus Rehab Centre.
Fantastic. And then I'm going to move into the big room where we've got Claire, Lewis and Freya. So if I start with Freya.
Hi, my name's Freya. I'm a third year physiotherapy student at the University of Winchester and I'm currently here on Lotus ward on placement.
And then Lewis.
Hi, I'm Lewis Hope and I am a rotational physio on the specialist neuro rotation scheme, and I'm also one of the therapists on Lotus Rehab at the moment.
Fantastic. And then I'm going to finish with Claire, who's going to introduce us, but also tell us a bit about the team, where you work and the kind of patients you treat.
Hello, my name's Claire Woodings. I'm a physiotherapist and I'm a team lead as well here on Lotus Rehab Centre. So the types of patients we treat were actually a recently blended rehabilitation centre. So we previously were two separate centres. One was stroke rehab and one was neuro rehab. We blended together and we formed the Lotus Rehabilitation Centre, and we take a wide range of patients in the adult population and from stroke patients and across the neuropathologies as well. We're a multidisciplinary team and we deliver our therapy across the team as well.
Fantastic, thank you. So these guys have chosen a paper for us to review today, and that paper is titled Stroke Survivors' Perceptions of the Factors that Influence Engagement in Activity Outside of Dedicated Therapy Sessions in a Rehabilitation Unit, and that is a qualitative study. And so we'll put the link to that paper below in the information below the podcast. And so this is a qualitative study, so we're going to use a critical appraisal tool to help guide us through the process. And previously we've used different appraisal tools for qualitative studies, but today we're going to use one of the CAST critical appraisal tools, and we'll also put the link to that down below. So before we start, I'm going to hand over to Shay, and she's just going to give us a little bit of a summary about the paper for anyone who hasn't read it yet.
Thanks, Chantal. So this, as Chantal said, this is a qualitative study and it was undertaken across 4 rehabilitation units in Australia, looking at stroke survivors' perceptions of the factors that influence their engagement in activity outside of therapy sessions. The methods that they used were semi-structured interviews that were undertaken by a speech and language therapist, and they used thematic analysis. And they also applied the themes to something called the theory of planned behaviour. They included 33 people who'd had a stroke, 60% were female, and they found that there were 5 themes. One was uncertainty about how to navigate the rehab unit. 2 was post-stroke mobility, fatigue and communication problems. 3 was the setup of the unit and perceived and actual rules, staff expectations. And the 4th one was family and friends were strong facilitators of activity, was what they found. And 5 was personal preferences and mood influences. So they concluded that at an individual level, stroke survivors perceive that their ability to be active outside therapy sessions is influenced by their impairments and their preferences. Is that it?
Thank you. So what we're gonna now go on and do is just work our way through the questions and think about some of the answers. So if anyone's listening, if you want to have your appraisal tool ready, go through, but I'll read the questions out as we go. So we'll start with question 1. The first question is, was there a clear statement of the aims of the research? So does anyone want to have a go at answering that and tell us what they think?
Absolutely. I think as a clinician working in this area, I think it's a really important question. I think it's clear in practice that patients are done to and tend to feel that they're losing agency, and we understand that there's an effect that it has on their ability to recover and to continue to do tasks on into the future. So I think they pretty clearly set out what it was they wanted to do, and that is absolutely valid in my view in the area that we work in.
Yeah, I completely agree. I mean, I think when I saw this come through from you guys, I thought like it was just the topic and the approach they'd gone was so useful for your clinical practice. When we go through the paper, we can really think about what the problems might be. But yeah, absolutely, and not only about useful for clinical practice, but useful to help inform improvement and kind of where you might change things in the future. So, yeah, okay. So they used a qualitative methodology, which is a much more exploratory methodology, different from the quantitative types of research we've data in terms of numbers. So what do people think? Did we think that qualitative methodology was appropriate?
Yeah, I think absolutely. You know, the aim of the study is to look at what people's lived experiences were, and I think the only way you can do that is by asking questions and talking and getting subjective opinions and forming those themes and ideas to answer the question.
Yeah, I completely agree. Yeah, I mean, I think for that question, that a qualitative method was absolutely appropriate. So yeah, completely agree with you there. So because we've answered those two yes, it means we don't have to chuck the paper in the bin, so we can carry on for the next sections. And it actually says that on the CASP tool, is it worth continuing? And we think that it is. So the next question, question number 3, is, was the research design appropriate to address the aims of the research? And so we're going to be talking about things like whether the researchers have clearly justified the steps that they have taken, and when they're discussing which methods they've used. So actually one of the things that I was going to bring up just really quickly with the CASP tool is that we have on the CASP tool, we have the options to say yes, we can't tell, no. And in my opinion, that's one of the CASP tool is very useful, but it's also one of the weaknesses of it in that it's very easy to whip through and kind of go, can't tell, I'm not really sure. And then does that actually tell us anything about the real quality of the paper? We try our best to give as much information as we can about the quality of the paper. So does anyone have any thoughts about whether the design was appropriate?
So I'll hop in here. Yeah. And I think it goes back to what we were talking about when we were talking around the importance of this paper given this population. And one of the things that I was quite curious about, not being an expert in stroke, is whether or not the sample was actually biased. And what I mean by biased is actually, did they look at a population that's relevant for us here in Portsmouth, or was it only really applicable to Australia, or actually is it even applicable to this population regardless of those borders? Because when you look at their table 1, which is their quantitative or their way of describing the sample, to me, given this is all about like trying to enable and to empower patients to be more active during an inpatient stay, to me, it looks like they pretty much only picked the patients who were going to be likely to move anyway. Like, so the scores on like their abilities and like how well or how ill they were, all of those scores were like not just average, like they were really low. Like for me, looking at one of the stroke severity scale, and I don't really know how that's determined or what goes into that because I'm not an expert, but that ranges between 0 to 42, and their average patient was a 4. Like that's basically 0 on a scale of 0 to 42. So I just really wanted to know whether or not, James, maybe whether or not you felt the same.
Absolutely. I think it says in the text that the patients had a pre-morbid modified ranking scale of less than 2, which is minimal or no disability. And that doesn't really reflect the cohort of patients that we see here in Portsmouth, who are often more elderly, often frail prior to their stroke, and so it is not reflective of the patients we see in this area. If I'm honest, it doesn't reflect our population in the majority of our population in Portsmouth. There are a few outliers that it might tap into, but overwhelmingly, the majority of our stroke patients are more frail prior to admission than they would be described in this paper.
Jay, did you want to jump in here?
Yeah, I would agree with that. And I think given that the population was less impaired, it could be that the types of barriers that they would experience to engaging in activities might be quite different as well. So it might be a little bit difficult to answer the question with this particular patient population.
That's really interesting. Would you guys feel, in your expertise, is that just here in Portsmouth, or do you think that actually that not reflecting the stroke population and this being an incredibly well stroke population, do you think that would be regardless of Portsmouth, or do you think that's just a Portsmouth specific characteristic?
I think it's difficult to say. We have, I think in the UK, I'm not sure what happens in Australia, but in the UK we have frequently have early supported discharge teams. So they tend to take people home to rehabilitate them earlier in their rehabilitation journey than potentially they do in other areas. I think the vast majority of the patients that may have been picked up in this study are likely to have been already discharged in the, certainly in our area, potentially in the UK. There are ESDs, early supported discharge teams across the country. So it's who tend to take people who are less frail pre-morbidly and more likely to be able to participate in the way that the participants participate in therapy in the way the participants in this study did.
I mean, it might be worth taking a step back actually, and just because absolutely the sample that they have used to draw the data, we're absolutely raising questions about whether that was the right sample in order to address this question. But in terms of the research design, it might also be worth thinking about how they got that sample. And so I think some of the things that they've kind of talked about, one is this data was collected 7 years ago. It was collected in 2015-16 and published in 2022. So there's quite and you think about the pace of change within health services. And it may be that actually experiences of people having a stroke are quite, they're kind of timeless really, like that's absolutely is absolutely going to stand the test of time. But I think about how rapidly services change, that whether that makes it slightly out of date. But I think, I don't know what you guys thought, but I thought one of the strengths was that it was multi-site and that they recruited from a variety of different rehab settings. And they did give us some information about a bit about the different settings, so that some were mixed rehab units and with different diagnoses. They talked a little bit about the physical design and the layout across the units. And again, I think that's very much about the importance of having a varied sample and that are providing their experiences, because you can absolutely imagine things like the layout of the unit and the structure of the unit would have an impact on their experiences of barriers and facilitators. So it'd be really good. It's good to have have participants from lots of different things. So that would definitely be a strength. Shay, did you want to say anything?
Yeah, I definitely thought it was a strength to have a number of different units. One of the things I wondered about was the fact that they were mixed rehabilitation units, and whether if it was more of a mixed unit, how well it was set up for the specific impairments and difficulties that you might find in a stroke population, and also whether the skill sets and experience of the people working in those units were focused on enabling people who've had a stroke. So that was just something that I wondered about as well.
Yeah, and I suppose my question then would be whether mixed rehab units, and I know that Claire's just talked about Lotus being a mixed unit, is a mixed unit a common way of delivering these services, or is it not a common way of delivering services?
I think it depends on what they mean by mixed. I had the impression from the paper, and I could be wrong, but that it was non-neuro conditions as well, which would be quite a different question to if you have neuro rehab alongside stroke rehab, because you'd be expecting to find some similarity.
I suppose there's an element of pragmatism there, isn't there? Is that these mixed units may exist, and therefore capturing the experiences of mixed units would add depth and variety to the experiences that are included in the theme. But also, it might also limit the applicability then, because if there's lots of input where the services are not set up, then you're not getting the information that actually you need in clinical practice, because you're setting.
So I think there's benefits, and like you say, there's negatives and positives to it. I think positively, we get an impression from the study of a typical patient's journey, if you like. So, a stroke patient in this area would validate what their findings are. I think it would be really a better question, perhaps, would be if you could compare the two. So, what are there any differences between the mixed units, or the outcomes for mixed units and the outcome for stroke specialist units? I think that would be an interesting. They've done all the groundwork for that. That would have been a really interesting comparison, really.
Yeah, and they don't really talk about. They don't do any kind of sub-analysis at all of their different population. And again, that wasn't their research question, so you could say, that they didn't need to do that. But yeah, absolutely an interesting concept that perhaps could look at in future research. The one thing in terms of the design that I wanted to kind of raise is that it seemed that this study was part of a larger trial. This, and I don't know how you pronounce this, ERESA trial, and it's not really common for us to have these kind of larger trials that might have these nested qualitative elements to them. But the thing is that I think because they've got this ERESA trial going on, they then omit some of the information that would be really important to us to understand this campaign study. So, for example, we don't really know how they recruited them. They don't give us any information about how they produced this sample. Was it convenient sampling? Was it just that I think they were only included because they were in the study, but because we don't know how the recruitment and the sampling process, whether they used for the ERESA trial, it's really hard to understand what's going on here. And there's been sort of some comments about whether it's directly with other patients, whether that's good enough, or whether you need to be explicit and include your the information in your paper, especially about some. Marie-Louise, Freya?
Yeah, I just wanted to pick up on that aspect of the ERESA trial as well. They've not indicated at what point they're in that trial. Are they at the gathering information bit? Have they modified? So the ERESA actually stands for altering the rehab environment to improve stroke survivor activity. So their plan is to look at how they might improve on their environment. So have they already improved it and this is their take on it? Or is this prior to them improving the environment? So is it that gathering data, looking at barriers? So they've not given us any idea about where the time frame for that.
I 100% agree. And actually, that's an incredibly important point that could absolutely bias the experiences of these participants. That they're in a trial that could be about, and it might not be about that. They don't really tell us. We don't know anything about that ERISA trial in this paper. But yeah, if it was about improving, and you get the sense that it was about trying to improve the setting and participation outside of rehab, that those participants could have already have had a better experience than other people. So yeah, very tricky.
I also wonder how much the eligibility criteria that they had fed into the trial beforehand, because one of the key points that they had was that they were able to stand with 2 people, and that, we know, prognostically is going to have much better outcomes than for quite a big population that we look after, where they might not be able to stand, and therefore their barriers to having for doing bits outside of their therapy sessions are going to be quite different.
Yeah, and again, I think that's that other kind of weakness, that we don't have information about this ERISA trial, and that very much helps us to, that kind of information helps us to understand more than the views and how much we translate that to our population. And so I think that's a real weakness in this, and would have been something that would be really easy just to kind of say, like, this study is part of this bigger trial. The bigger trial is aimed at doing this, this, and this. This is a nested qualitative study within that. They easily could put that in, but it's a real shame that because it would have given us useful context. Okay, I'm going to move on to the next question, because otherwise we could talk about that question for ages. We've covered some of this already. Question 4 is, was the recruitment strategy appropriate to the aim of research? And so we've already talked a little bit about the fact that we think that the population that they did recruit may not be representative of your population, possibly the UK population that are having rehabilitation in specialist unit. And we've talked a little bit about the ERISA trial. Did anyone else have any other comments to say about this particular population? So were the participants they selected the most appropriate to access the type of knowledge sought by this study?
I suppose there is an argument to say that you could extrapolate from what they found here to the wider stroke population. I think, because although these guys might have been participants, might have been more fit and less impaired by their stroke, I think what they're actually looking at is bigger than that. Is being able to control your environment, work within your environment important. So it doesn't matter whether they are fit and able or they're not fit and able. That's the question that needs to be answered, is moving around your environment, is able to participate in normal life activities in a hospital setting important? So I guess that you could say that it is. Yeah. I don't know.
I think one of the things that the findings are really interesting, and a lot of them focused on the kind of impairment issues driving that difficulty to engage outside of therapy. And so if you think it's impairment based, if our population is not very severely impaired, then you can only presume that your population would find these issues even harder to navigate. We couldn't say that for sure. Like, this evidence doesn't tell us that, because it doesn't include that population. But it could get you thinking along those lines, and then perhaps when thinking about how you might apply that. One of the things we talked about earlier was about aphasia, and Jim, you were talking about kind of communication issues. So we think 24% of the people in this study in table 1 seem to have aphasia. I don't know much about aphasia.
So it's difficult to, well, they didn't describe how the steps they went through to ensure that the aphasic patients were able to consent to the study. Really, one of the key tenets of the Mental Capacity Act in this country is that people are able to communicate their decision or communicate their consent to a particular intervention or thing. So it doesn't necessarily mean that people with aphasia can't consent, and in many instances they can, but I think to make the study more robust, they probably should have described the steps that they went through in order to make sure that the patients, particularly aphasic patients, were able to consent. I mean, that would apply to people with cognitive impairment as well, to a degree. We can't just say, we need to understand that the people are aware of what they're signing up to before they sign up to it, and they made no real effort to show how they did that.
Yeah, Rosalind?
So I totally agree with what you were saying there, Jim, in that, like, especially given in the, and I'm not familiar enough with this sort of research area. One of the biggest strengths that the authors claimed in this study was the inclusion of these individuals who were either aphasic or dysphasic, and they didn't talk at all. Like, I mean, as a researcher, knowing how they facilitated that, both from the consent point of view, the data collection point of view, and the data analysis point of view, to me, I'm like, tell me how to do that, because those voices that aren't typically heard are really important to include in research, so that we do make sure that our clinical practice isn't just for those people who are easy to access, that is everybody who's important to our service. So I really would have liked a lot more detail around how they were accessed and how that consent was facilitated and the data collection was facilitated, because if you're doing interviews and you've got somebody who's dysphasic or aphasic, how do you interview? Like, did they do a written interview instead of a spoken interview? Did they use a computer? Like, how did they do it?
Yeah,
absolutely. And aphasia is a spectrum. You know, people can have mild word finding difficulties at one end and complete inability to understand language at the other. And I'm just looking at the table that they use. So they scored aphasia using the NIHSS, which is a fairly blunt tool in terms of aphasia assessment. That I'm sure what they probably could have considered is using a more specific aphasia outcome measure or scoring tool, which would have given us a better idea of how aphasic these patients are, or what communication difficulties they had.
That was one of the design issues actually that I'd raised, that what the data they collected to describe the population, you don't normally get that detailed in qualitative studies. So it's very likely that has come from the ERISA trial, that those outcomes, but because it's come from that trial again, we don't get any information about why they selected those tools, why they measured those particular aspects. Whereas normally in a qualitative study, you'd be absolutely justifying why you're looking for this diversity in your population, and they don't do that. Claire, Lewis,
Yeah, I was just going to touch on a point where they said that they had 59 participants that were eligible, but they only actually interviewed 39. So that's quite a large percentage of participants that didn't participate, and there's no real indication as to why they weren't properly recruited onto the study. And it should just be interesting to know whether, is that because of the level of aphasia they had and therefore they weren't able to fit the format that they were trying to do, or you know, what was the reason? We just don't know.
Yeah, totally agree. And I think in a study like this, especially where it seems to have been involved a lot of these what do they call them? Speech pathologists. That you would have imagined that you'd be looking at designing a research study that was the most accessible to a group of your population that might really struggle with some of the issues that are being raised in here. So that was definitely a real weakness. Okay, and that kind of takes us on quite nicely to question 5 about, was the data collected in a way that addressed the research issue? So we absolutely have a group here within this study, and perhaps within the larger ERISA trial, that made the data collection method may have been entirely inappropriate for them. And actually, linking into the consent and the ethics side of it, it may also have been a data collection method that caused problems for those participants, that made them feel particularly frustrated, made them feel excluded again. And they don't really talk about that. And we're going to come on to talk about some of the ethical issues in a minute. Did anyone else have any thoughts about the way the data was collected? And if we look at our CAST tool, if people are looking at it, there's prompts down the side that if anyone had any questions about that.
Yeah, I think quite a bit of it we've already talked about is that we just don't know a lot about how they supported, in particular, the patients or the participants with aphasia. What, did they use assistive devices? Did they use a caregiver? Did they use various communication tools? We don't really know. So we know that they use semi-structured interviews, which may or may not be appropriate. Within that setting, if you're one-to-one, you at least have probably a little bit more of a chance of meeting individual needs rather than, for example, if you used a focus group. But yeah, we don't have probably as much information as would be helpful to understand exactly how they went about it, really.
Yeah, sorry, motorbike has just gone past my window. And what is that got all picked up on the camera? Lewis, you mentioned something in our earlier discussions about, which I thought was really important, which was about how do we know they're asking the right question in their interview?
Yeah, I think to me it just seemed like in the supplementary interview guide that they had, that there seemed like there was some preconceived ideas of what they already thought the barriers were to people participating. And a lot of those questions were formed based on that. And I think for me, like, an important thing is not only those extrinsic environmental factors, but also, there's intrinsic reasons as to why people do and don't do things. And maybe they haven't captured some of those, or it just didn't seem to be enough openness in terms of exploring what the participants themselves felt like the issues were.
Yeah, and I think you've touched on two really important points there. One is that it seems like their interview guide came out of nowhere. And probably came out of their own heads. And so then we've got that question of, are you asking the right questions? And so in some qualitative studies, we see interview guides that have been developed in co-production with a group of patients that have been very much based on a good foundation of patient and public involvement, so that we've got a sense of what the questions might be. What we also can see in some qualitative studies, which they don't talk about here, is that ability to react to what's happening in the interview. And so they might have a guide, and they talk about using a semi-structured interview guide. That kind of implies that they did this, but again, we're back to that implying again, really, rather than explicitly telling us that you would expect that they would be able to be really flexible with their interviews. And so if participants started telling them about something that wasn't included in their guide, that they could shift the conversation in that direction to make sure that that they were including all things that were important and not just what they thought was important. So I think that was a really good point, Lewis. Okay, let's jump on to question 6. And so this is quite an interesting one, because has the relationship between the researcher and the participants been adequately considered? This absolutely does happen. One of the key components is research activity. And so does anyone want to talk to us about what they think about the relationship between the researcher and the participant?
And from my perspective, it just wasn't overly clear as to what the relationship was at all. And we've spoken quite a bit about speech pathologists, and are these people that have worked with those participants in the past, and rightly or wrongly, do we assume that they already have an idea and awareness of how they're best and optimally to communicate with these people? It talks again about.
I just want to ask you another question based on that. Do you think that participants would give you different information if they knew you or if they didn't know you? Do you think there could be a difference there?
That's a good question. I guess it depends on what they're talking about, and one of the points that they discuss in here is about the expectations of what the therapist is asking them. And I guess if you're going to have conversations like that within the interview, then it depends on how much the participant's willing to open up about those problems with the familiar face in front of them.
Yeah, and again, we seem to have speech pathologists doing the interviews. Then we have occupational therapists and physio students doing some of the analysis. And then we've obviously, because we got Shay and she knows about who some of these people are, we've got some physiotherapists that have designed the research and come up with the questions. So we've got loads of kind of different people that are influencing what's happened in this study, but we've got no critical examination of how that influence has affected what's happened in this study. And so that's one of the kind of the really key underlying principles of qualitative research, is that as a researcher, you absolutely have an influence on what's happening on research. You will, if you know the participants, depending on your relationship, if you had a really positive relationship, they might open up to you more, or they might skip over things in the interview because they know you've experienced it with them, so they don't cover them, so you miss that data. Shay, did you want to come in?
Yeah, just to reiterate the points that you're making, really, that being explicit about in your discussions about the reflexivity and the importance of, or how the existing relationships could influence things is just so important, and it really is missing from this study.
And actually, Jim, when we were talking earlier, you had a really good point about the theory of planned behaviour, which kind of underpins what they're doing here. Sure,
I mean, they mention in their introduction that both for the design of the study, that the environment can enrich the rehabilitation and improve the motor recovery of patients, and also that the theory of planned behaviour is behaviour theory that's evaluating physical activity, whereas what they then go on to ask their aims of their study are both physical, cognitive and social activity outside of their normal therapy sessions. So they're using, they seem to be biased towards a motor and physical outcome for patients as a good outcome, and sort of not necessarily looking at why, how they cognitive or social outcomes for patients, which is equally as important. As I said in our earlier discussion, as an OT, that's, you know, it kills me every time that I see as a motor outcome from a stroke study, because, you know, stroke recovery, stroke rehabilitation is so much bigger than that, and so much more important to people, that they can do everything they want to do. It's not just movement. Movement's an important part, don't get me wrong, but, you know, being able to think is a really important thing to be able to do after a stroke too.
Yeah, so even that choice of that theory of planned behaviour will have been influenced by the researchers in this project, and knowing more about who they were, what their and in research we often call it their ontological and epistemological position. So how do they view the world, and how do they view how we gather knowledge about that world, that we don't have any information at all in this study about their positions, where they come from. We don't have any information really about their kind of their experience and their backgrounds. We know a little bit about their professions, but that's about as deep as it goes. I'll first go to Shay, because your hand came up first.
Exactly. Again, you know, you can dig a little bit and go, okay, well, I can see that the lead author is a physio, and I can see that there are other physios there. So as a physio, I can make certain assumptions, but you just don't have any description of it. You've got to go digging, and you've got to do that thinking yourself, which is then influenced by your own biases and profession and that sort of thing. So yeah, it really is.
Definitely. Ross, did you want to come back in?
So I think sort of relating to this is something that Lewis raised in our previous discussion before we started recording, that kind of ties into this whole like worldview and what you believe about knowledge and how you believe knowledge is formed. And he identified straight away, which I thought was really, really good, actually, how they described their analysis. The themes just sort of magically appear, and by coincidence, they pretty much are the exact same as the theory that they used. So like it could use with a little bit more of a detail. And I'm not saying, you know, they did anything shady, but it's about taking the reader with you so that we can see, actually, have you just regurgitated that theory that was the basis of your exploration, or did you actually find that theory in the data and it wasn't a regurgitation, it wasn't a force of a fit, that actually this is what the patients are saying, and so we need to use this theory as a framework to restructure how we build. And that bit I found, even in the discussion, was very limited. It didn't really help us see how they'd done it or how they'd come to that conclusion.
Claire, Lewis and Freya?
Yeah, I was just curious as well about, in the results section, it comments that 6 of the 39 interviews that were conducted, that 6 of them were conducted for training purposes. And is that the norm, that you dabble a little bit first, and does that then influence your questions going forward? Or?
Well, that's a really good question. You absolutely can do some pilot. We probably think of them as pilot interviews. And again, depending on how experienced your researchers were, then you can absolutely use them for training. And you can also exactly do what you said, is use them to make sure that your interview guide is right, is asking the right questions, and that people are not bringing something up in your training interviews. However, they didn't tell us that they did any. They just kind of brushed over it. And actually that, if they'd have told us that, they'd have said, we use these 6 interviews to train our staff, but also to test our interview guide, to make sure that we weren't missing any important areas, to develop it, and to make sure it is accessible to our patients with communication issues, blah, blah, blah. That would have answered so many of our questions, but they didn't. They just glossed over it. So yeah, really good point there. I'm going to jump on to question 7, which is about ethical issues. And we've talked a lot about some of the ethical issues already. We've mentioned about the concern about consent for our aphasic participants, and also whether they were meaningfully able to contribute to the interviews, and whether the interviews caused any problems for them in terms of frustration or upset. And again, they didn't really talk about whether the research process could have caused any detrimental effects to their participants. But the one thing that I just had down in my notes that I wanted to say was that they seemed to consent them at the beginning in 4 weeks of their rehabilitation. And I think this again was very linked to the ERISA study, and that they had to have had when they were eligible in 4 weeks of a confirmed stroke. But then these interviews didn't happen until they were 2 weeks post-discharge, or within that period. And we have no idea how long that period was. And we have no idea about whether they re-sought their consent at any point there. And so there's a bit of an ethical issue there about whether that original consent stood, and whether they still wanted to take part at the end. Rosalind?
So 100%, and this is something that I really thought was missing in this project. So being somebody who's done mixed methods myself, it can be really hard to keep putting everything back together. But like, although they mentioned it's part of a bigger study, they didn't really give any clues as to how they informed each other, whether or not it was a second consent or any of those sort of processes around those ethical issues, like the timing, like all of that sort of like, how did you make it happen? That is missing in this paper. And I think it's one of the really big struggles with having a multifaceted research project is when it comes to reporting it, you might have written a protocol somewhere else, you might have written a quant paper somewhere, you might have now have this paper, and it's about giving your reader enough clues that you know you can find it somewhere else. And I didn't see those clues in there. Yeah. But again, I think it ties back into, like, I kind of feel like in some ways we're starting to hit this paper with a really mean stick. And I think it's really important just to note that actually what we don't know, and what I've experienced as an author, regardless of the style of paper that I'm submitting, is sometimes your hands are so tied by like the journal set out. And so I think, although this might sound like we're saying this is a horrible paper, I think that's, for anybody who's new to doing this sort of thing, I'd say, you know, look at some of our other things. This is pretty typical of appraising a paper, and it doesn't necessarily mean that we throw the paper out or disregard the paper, but actually it's about just being able to really critically evaluate it before you completely agree with everything they say.
Yeah. Claire, Lewis and Freya?
I think that reading the paper and our discussion that's come up from it, with all of these questions surrounding how they've done certain things, it definitely feels like the paper's been limited by a word count, and perhaps that they've chosen wrong things to focus their words on, when we're left questioning other bits that are potentially more important.
And I think that's such an important point, and more now you see qualitative journals without a word count, so that we can actually get all the important methodological information in, as well as all qualitative papers are going to have a massive results section compared to your quantitative papers. So yeah, I think that there's kind of that shift towards qualitative submissions without a word count is really useful. And again, I don't know about clinical rehabilitation, whether it does have a word count or not. But yeah, it could well be word count really limiting this. Okay, I'm going to move on to question 8, which is just about the data analysis. Did anyone pick up anything from data analysis? So one of the things I'm going to pick up just quickly, which we have talked about, with data saturation, a bit of a controversial topic within qualitative research. They kind of, what tends to happen is people just chuck it in and say data saturation was reached. But actually, there's a really great paper signpost you, and I can try and find it and put it in the link below, by Braun and Clark, that absolutely talks about data saturation and whether it's a real concept with qualitative research. Is it ever possible to reach data saturation, considering the fact that the researcher is such a key part of the process? And so if you stuck a different researcher in there, would they find different themes? And also, because if your participants were broader, would you find different themes? So just something to think about there. Shay?
Yeah, I think you raise a really good point with that aspect. And when we've talked previously about the rigor of the data analysis, again, one of the things that we said was it just felt we were lacking in some detail. There were just quite a few we're not sure. And again, it might just come back to that question of word count, which I think is really important to that we've touched on that as well, because absolutely we're not just slating the paper and saying that it's rubbish. There's probably a lot of stuff that or potentially a lot of stuff that hasn't been able to be in there. However, when we're looking through it, we're not really certain about how they've done things. I've said, like we said earlier, that thematic analysis was used, and they've sort of regurgitated steps on how you would do that, but not necessarily given us a big description or any description really of how they've done it.
Yeah.
So yeah, it's just really that the description could have been more explicit. And again, we didn't really get to the bottom of how the themes were generated from the codes. So yeah, I think that it was just lacking in some detail there, so that we could really say how rigorous it was.
Yeah, completely agree with that. And I think sometimes a table is a really great way to do that. You can take it out of your word count and you can show the steps, but you can then describe what you did as a team with those steps, because even though they've got all the steps, everyone does it a little bit different. And it's those differences that you kind of want to know about. So, okay, I'm going to move it straight on to question 9. Is there a clear statement of findings? So when we were reading this, did we feel that we could kind of come away from it and go, yeah, I think I know what they're trying to say? I'm sorry now that no one thinks that they are. Actually, what I'm going to do just because this very much links to the kind of the last question that we normally close with in this podcast, is that is thinking, and it absolutely hits back onto that kind of statement of findings. Is so just getting you guys to think about reading this paper, and we know of the weaknesses, and we acknowledge some of those may be due to reporting rather than lack of kind of actually going through these processes. But what do you guys think are the implications from the findings of this research for your practice? How would you take this, and what would you do with it?
I think it's not telling us stuff we don't already know. I think it's come back with a result that, it reinforces what we think, I guess, which is a good thing. But it doesn't. It tells us, change the unit layout, do things differently, include patients in social activity, and we already know we should be doing that. It's like, why are we not doing that? That's more important. What can we do to help us to do those things? So that's my take home. It's that I don't think it's told us anything I didn't already know in my heart. It's added some validity, I guess, to that in terms of taking it through a research process. But what I want to know is, how can we do that?
Yeah, actually, future research could be about what are the barriers for clinical professionals in implementing some of these strategies. Yeah, Shay?
Yeah, and I wonder what a research trial itself findings there might be as well, because that's at enriched environment as well. So that might be a little bit more of the how. So that was just one of the points.
Yeah, I think, sorry, I just wanted to say, I think that a hospital environment is a very alien environment. Now, we all work in it, and we've all worked for a long time in a hospital environment, so it's very familiar to us. But for patients, it's completely unfamiliar. Even the fact that you're sleeping in a bay and there might be several people sleeping in the same room as you in what feels like a dormitory again, is very alien to them. The kind of aspect of privacy is very, I don't know, it just feels like that's not available to patients. So I think there are some quick wins that we could really think of as teams, as well as linking into bigger trials as well. I think we can start to think about what are our easy wins that we could do for our patients.
Yeah, so obviously I don't work in on the stroke unit, and my department is a prosthetic outpatient department. But I was even thinking about how these results might apply to my department, and absolutely about kind of navigating people around the department were kind of really basic, like you say, quick wins that you could easily do. But one of the things that I thought was quite interesting was that kind of that feeling that patients were allowed to do certain things.
Yeah.
And obviously that was quite important in the stroke unit, but I think within the prosthetic unit as well, it's like, well, yes, you should be allowed to go and move around and get a cup of tea, do whatever you kind of need to do, because you're often here for hours while you're waiting for your leg. But I sometimes wonder how much that's in attention with our constant security issues and challenge people without a badge and all this kind of stuff, that you've kind of got this tension between, like, yeah, there shouldn't be anyone moving around that, there's not allowed to be. And yet patients should feel like they're able to do what they want to do. And so you kind of got this horrible tension that almost makes it really difficult to apply some of this stuff.
I think there's a lot of...
Sorry. Yeah, go for it, Lewis.
I was just going to say, there's quite a few like taboo topics, isn't there, with like infection control policies, health and safety policies, and what we can and shouldn't be doing. And I think I've certainly had really positive experiences where everyone in the bay is allowed to have a shared experience together, and having that sort of group ethos. And I know that's not for everyone, but it certainly helps try and tackle some of the issues that people have got with boredom and trying to keep stimulated throughout the day.
Yeah. I can't remember who came in first. That was Shay and Rosalind, but I'll go to Shay first. Sorry, Ros.
Thank you. I think that what will be really interesting is the outcomes of some of the future research that I'm talking about in asking similar questions of other stakeholders, which I think is really interesting, because I think as clinicians and people who work on these units, there are things that we can do. There are some quick wins that we can try and look at, and actually that's stuff that we can do. But from the perspective of the organisation and the all the things like infection control, all of that, some of that's actually out of our hands. So understanding the viewpoints of other stakeholders is going to be important, so that we can tackle these sorts of issues from lots of different perspectives, and not just what we're doing as clinicians, I think. So I thought that it was important to think about the influence of those bigger.
Yeah. It absolutely is those kind of like, you've got drivers within the hospital in terms of kind of safety and risk and what have you, and how much those drivers then outweigh the importance of getting a good outcome, which is why you're there in the first.
Exactly. And I think just one other point I wanted to make about sort of how we can apply this to our work is, because we've talked about how the participants were less impaired than perhaps some of our patients that we see. You could hypothesize, at least, that the experience of the patients that we do see is going to be even more difficult in regards to these things. So it kind of just gives you a bit of a taster for if people who are not very impaired or less impaired than perhaps some of the patients that we see are finding these things difficult. We'll imagine how hard it is for the more impaired patients.
Yeah.
And also quite a big population that we see they'll live in a demographic where they don't have close family members, or they might be the only one. And actually, one of the key points out of this was how family and visits was such a big part of like keeping them going. And actually, we've got numerous people that just don't have that social support network, and therefore does that then come on the MDT to try and facilitate a little bit more for those people being a bit more vulnerable.
So using this kind of information to target your interventions, or particular interventions at particular particular patient. Yeah, sounds really interesting. Rosalind, I'll come back to you for the final point and then I'm going to close.
So just very, very quickly, one of the things that I think is interesting, so with doing this Evaluating the Evidence podcast that we've been doing, we did you should check it out. There's another earlier episode around deconditioning in a hospital. And I think there's some real parallels here is that, yes, a hospital is supposed to be rehabilitating people, getting them better, getting them strong enough to go home. But regardless of whether it's in a rehab unit or even within cardiology, we know that patients who come into hospital usually get discharged worse off. And I think there's some real things around looking at, that deconditioning piece, that environment piece, even how they use here, that theory of behavior in order to reevaluate and reset up a much more permissive and promotional environment so people can actually try to get better. And something I found in my research studies looking at heart failure patients is it was something that my interviewees said a lot of times. They're like, I wanted to go for a walk, but there was nowhere to go. And I was scared to leave because what if I missed the doctor and then I never saw them? And all of those sorts of issues, or I was attached to a pole. So how can we make a hospital environment one where we don't decondition our patients and where we do promote that healing and that rehabilitation?
I think that's a brilliant place for us to end. So thank you everybody so much for joining us for the podcast. And thank you to the wonderful Lotus team for your thoughts and your views and for finding such a fascinating paper. So if anyone would like more information about the Lotus unit, then they can contact these guys. We'll put email addresses in the links below so that you can contact people. And if you'd like more information on clinical academic careers or research practice, then we also normally have the links below, and feel free to get in touch. So we'll see you next month for our next topic in Reviewing the Evidence series, which is going to be a mystery because I don't know what it is yet. But we'll see you next time for that. Thanks everyone. Bye.